hard
Oh,
to imagine what the motivation would be for bringing people down. I think very occasionally I've had a patient say to me something about money, like you just wanna give me this treatment because of money. And weirdly, it's usually about electroconvulsive therapy. And honestly, that is the worst paying thing that you can do. And I mean, it's so there's just there's no strong financial motivation to go into psychiatry. When you're in medical school, everything else is going to lead to a better, lifestyle. And there's, within psychiatry, very little in the way of financial motivation to offer one treatment, or another, generally speaking. So it kind of baffles me, but also, right. I mean, that's the perception that people have. And I think it's coming from a place of sort of fear and media and yeah, all that stuff.
hello, everyone, and thank you for tuning in to the Truth That Heals podcast. I am your host, Ryan Anthony Hernandez, and for today's episode, we have a very special guest. Coming all the way from Seattle, Washington, is Dr. Rebecca Allen. Now, for this interview, we're going to be discussing a variety of things from mental health, psychiatry, depression, and there will be parts where we discuss cult behaviors. But an important step that I took as an interviewer was seeking to understand who is Dr. Rebecca Allen? What were her motives? What drew her to choosing this career path of becoming a psychiatrist? And it wasn't only important for me as an interviewer, but more so it was important for me as a cult survivor to ask those questions. Because being in an end times cult for 11 years, the way we viewed psychiatrists and the study of psychiatry, it was demonized. They were seen as the enemy. They were seen as pill pushers just trying to take people's money. So it was very important for me from the very beginning, getting to understand who she was, what were her motives. And Dr. Rebecca Allen does an amazing job at walking me through, or rather in walking us through, into understanding what the journey is like to becoming a psychiatrist. All the years of hard work, all the dedication. It was very interesting. It's a very interesting interview. And from there, we jump to other topics in our episode in this interview from, like I said, from the cult behaviors, but also we mention other things like movies, TV shows, and there's even a mention of Eeyore from Winnie the Pooh, which is very interesting. So this was a very I really enjoyed this interview, and I hope that you, the listener, or if you're watching this on YouTube, the watcher, I hope that you enjoyed this interview as well. And if you have not yet subscribed or followed on whatever platform you are listening to this episode, please go ahead and subscribe or follow, give a like, and share this with others, as this really helps to grow this channel, the Truth That Heals podcast. And without further ado, here is my interview with Dr. Rebecca Allen. Thank you. Hello, I'm here with Dr. Allen. Hi, doctor. How are you doing?
Hi. Hi, Ryan.
It's great to have you here on the Truth That Heals podcast. And before we really get started, could you kindly introduce yourself and share with the audience what it is that you do?
Yeah, of course. I'm a psychiatrist, and within psychiatry, I'm subspecialized in neuropsychiatry, meaning a little bit more focused on the overlap between psychiatric and neurological problems. And what my practice does, the treatments that we offer, we call interventional psychiatry. And people debate what that term means, whether that's the right term, but what we're saying is that we do the kinds of treatments that are a little bit more difficult to do, that are the kinds of treatments that you wouldn't offer somebody the first time they ever come to see a psychiatrist, but you would offer after they have tried multiple easier treatments, talk therapy, medications you can take at home, and then would come to us and say, gosh, these things really haven't worked. What else is there? What can we do? The kinds of treatments that we have at my clinic, we offer electroconvulsive therapy, which is sending a little bit of electricity into the brain to start a therapeutic seizure, which works extremely well. And I think we're going to talk about that later, probably. We offer transcranial magnetic stimulation, or TMS, and that is using magnetic fields to stimulate the brain in order to treat mental illness. And there is also ketamine, and we offer intranasal ketamine, both the FDA-approved kind and also the generic kind. And we have intravenous ketamine, ketamine-assisted psychotherapy. We offer also vagus nerve stimulators, which is an implanted device that stimulates the vagus nerve in your neck. It's also treatment for depression. And we have some clinical trials that are happening where we are participating in large multi-site studies looking at whether new treatments work or don't work in sort of the early stages before they get to the FDA, who can then look at that data and decide whether to approve them or not.
And for how long have you been practicing as, Dr. Allen? How long have you been Dr. Allen for?
Well, so long journey. When you become a physician, first you go to college. So I went to Stanford and got a psychology undergraduate degree, minor in fiction writing. Then went to medical school and I got also a master's. So I got my doctorate in medicine, so my MD, and I also got a master's in public health, and that was in biostatistics and epidemiology. When I left medical school, you can't practice right away as a physician leaving medical school. You have to do a residency after that. And that's when you're first called doctor. So, but you are not independently practicing for another few years. So for psychiatry, residency is 4 years. So I went to the Harvard Longwood Psychiatry residency program, and I was in Boston for 4 years for residency, and then stayed another 2 years for fellowship in behavioral neurology and neuropsychiatry. So how long have I been doing interventional brain medicine? That was really when I left training and took a job where the practice where I took the job was offering electroconvulsive therapy and transcranial magnetic stimulation. And that was in 2017. I was in my mid-30s. So I became a fully independent practicing physician in my mid-30s, and that's not atypical.
I'm very curious to knowing why. Like, why did you pursue this career when we see in the media, or like, for example, in some movies like Shutter Island, or in One Flew Over the Cuckoo's Nest, where viewers might get the idea, man, these doctors, they're just trying to experiment on me, or they're just trying to lobotomize me, or they're just trying to torture me. Uh, but from my understanding, that's not the case. That's not the whole story.
No, and I think that one thing to keep in mind is these days, and by these days, I mean many decades at this point, it's very, very difficult to treat anyone against their will, even if they really desperately need it. So we have situations where a kid is suffering even close to, having really bad medical problems from being bedbound from catatonia, and you need to wait months to get a court order in order to offer them the treatment that works, because the parents aren't allowed to consent for some treatments. So the situation right now is very much the opposite. I don't end up treating people who don't want to be treated. People come to me, they come to doctors in general, to psychiatrists seeking help. And when a person is seeking help, there is very little that we can offer that a person wouldn't be like, oh, yes, I want that, right, after having a conversation. So informed consent and independence, that is the nature of medicine these days, not just psychiatry, but medicine in general. So in rare circumstances in medicine, when you're going in like after a car crash and you're going into an emergency department and you're maybe not conscious, yeah, there's going to be a lot of medical care that happens without talking with you about every single step and asking for your express permission for every aspect of it, because if they did that, you might die, right? But beyond that, in medicine these days is very much about patient autonomy, about teaching, about explaining to to somebody who's coming to see you, hey, here's what I think is going on. Here's why I think it's that. Here's what else it could be, but here's why I think it's this that's going on. And here are some options for what we could do about that. And talking through what these options are, what they mean, what the pros and cons are, and then really having that conversation where a patient can, and often with support people, spouse or family member, make a decision about what is the right path forward for them. So that's the norm. And when that doesn't happen, that's very much the exception, sort of more urgent matters. So in terms of some other things that you said, lobotomies, I think the Scientologists bring that up pretty frequently. Lobotomies never did work. And there was one particular guy who promoted them for a chunk of his career, and his life ended for him. I mean, I think he deserved it probably, but ended very sadly because he went around and visited a lot of his old patients, trying desperately to show that what he had done actually helped. And it didn't. So lobotomies, over history, there have been different kinds, but this was the guy who did the ice pick lobotomy. And I'm going to say, I don't remember his name right now. But the last one of those was done decades ago, when you and I were both children, or maybe even before we were born. So the thing about lobotomies is that because one is portrayed in One Flew Over the Cuckoo's Nest, it's sort of, and that's a really great movie, by the way. I mean, I actually think as a piece of art, it's lovely. It's portrayed, it's still in the collective conscience. It's still part of our culture that people have heard of this because it's in that movie. And then I also have heard, and I was pretty surprised by this. I'm not a lot on sort of Twitter or X or Instagram, but I've heard that there have been a spate of sort of people posting videos of like, lobotomy face or something like that, which I find very, very disturbing. In any case, though, what you're describing, those fears are, it's the opposite. I mean, we have a hard time getting people care who need it. We do not have care that we're throwing at people who don't want it.
Thank you for shedding light on that, because what I'm hearing is that there is respect for the person, there is dignity, and you're also involving, as you said, like couples, family, trying to get
Right.
that support for the
Yes.
person, as well as informing them instead of being like, come here and,
Right.
strapping them down and then getting the ice pick. And that was at a time, and I even mentioned this to you before we started the interview, that I was in is this religious movement slash
Yes.
cult, which had
Yes.
very negative views towards mental health.
Yeah.
Uh, but I really value mental health, and I really value that you've established from the very beginning that each person is treated with respect. Now, before we even continue, I would like to ask, what was it that drew you to this career? What was it that inspired you? And did you like fall in love at first sight with when you saw neuropsychiatry? Or can you walk
Oh,
us through that?
way before that. So so there were a couple of personal things. When I was a child and a teenager, when I was a little child, my grandmother had a stroke, and how her brain was affected, what she could and could not do after that stroke, was very interesting and sad, and I loved her. But the way that it happened is I spent most of my time as a child and a teenager knowing her post-stroke, and my memories of who she was pre-stroke faded and faded more and more. And that was unique, I think, among the people who knew and loved her, because her own children thought, my mom, actually, she mostly went away when she had that stroke. In the 15 years or so that she lived after that, she was considered to be, not the person she'd been before. But to me, that's who she was, is my grandmother after she'd had this stroke. And she could repeat things that I said, but she could very much not generate words of her own. And when she did generate words of her own, they were often words that didn't quite match what the situation was. So she could say yes or no, but she often mixed them up and said yes when she meant no, and vice versa. She could, to some degree, control what she said. So she did have swear words in her small, vocabulary of words she could generate herself. She didn't say them in front of me when I was a little kid. She could say, my, goodness sakes, oh no. So these phrases that are sort of a bit generic, and she could have prosody, meaning her voice could go up and down and be very expressive. And she could repeat after me anything I said. A moment later, she could say that, short words, short phrases. So I thought that the brain just must be so interesting, fascinating, complicated that a person could get that array of problems that seem sort of inconsistent or not matching. You think kind of logically, well, a person can't talk, they can't talk at all, right? Or if a person, can't understand speech, they can't understand at all. And that's not really how the brain works. And so I became very interested in that. Also, she had the right side of her body was paralyzed, but her stroke was on the left. And I thought, that's weird too. So I became really interested in the brain. And in terms of that translating to mental illness or to psychiatry, I come from a family where multiple people in my family have had depression. One even had psychosis. And my family's attitude towards people seeking care, seeking mental health has been not very good. So nothing like what you've been through, but just a little bit of a touch of that stigma has run through my family's attitudes. And my uncle, who was the one who had the psychotic symptoms, he did commit suicide when I was a teenager. So thinking about those experiences, the interest in the brain, the interest in mental health, when I went to college and beyond, I already very much knew, something to do with the brain was what I was wanting to do with my life, with my career. It refined over time. In medical school, I really thought that I would be a neurologist. I got very interested in multiple sclerosis. I got interested in Parkinson's. When I did rotations, though, where I was in psychiatry, I found that I connected with the patients a lot more, who had mood disorders, who had thinking and memory problems, cognitive issues. I I felt like that was maybe not as common as it should be. I heard a lot of medical students around me saying that it was much harder for them to talk with people who had mental illness or empathize with people who had mental illness. And I thought, okay, well, maybe this is a thing I should do. So that's the direction that things went.
Well, you mentioned a little bit earlier how about the stigma that was in your family regarding mental health.
Yeah.
And sadly, there are people in scenarios where they want to climb up, they want to perhaps follow their dreams or pursue a certain career, but because of those around them, they stay in that box and they don't accelerate forward. What was it that gave you that perhaps grit to just say, I know people around me are having the stigma towards mental health. I'm still gonna go for it anyways.
I mean, I think what helped is that I never had it. I was surrounded in high school by peers who talked about having depression and who talked about going to therapists and people who were on ADHD medications. So to me, that attitude felt very much like a generational difference in my family. So I did not have that same attitude towards psychiatry, at least that I not that I can remember at any point. And when I thought about what do I want to do, who do I want to help, what is an area where I can, perhaps make an impact or feel passionate about something, but this seemed like the right thing to do.
And you've been doing this for a certain number of years now. Has there been a day in your experience where you just stopped and you just said, "Wow, I just made an impact on someone's life"?
I mean, yeah, I think when I see a person who has been struggling for many years, who has gone in and out of depression, who has felt for a lot of their adult life like they don't want to be alive or like they want to kill themselves. And they undergo a course of treatment and afterwards are feeling excited about life, feeling like they want to do things, feeling like they're motivated. That does really hit hard as like, wow, this is a really, good field that I'm in, a good way to be helping people and really making an impact. Yeah.
And I ask that because in this career that you're in, it's very dark. And you mentioned how there are people who have depression and they're in that dark cloud. And to hear that you're bringing not just that mental healing, but perhaps we could even say hope to someone, I think it's very powerful. But unfortunately, there is a lot of stigma regarding mental health. And have you encountered, uh, because you mentioned earlier that you never force anyone, you don't force people to get mental health. You wait for them to come to you. Have you encountered the patient or the person who, they're seeking help, but they're afraid to, or you see that they're having a hard time? How do you connect with them so that they're able to kind of break those walls and be open for that healing journey?
Well, I want to address one of the things you said in your lead up to the question in your premise. You said never, and nothing's a never. So there are circumstances where a person is in the hospital because they've done something that is dangerous to themselves or dangerous to others. They're hearing voices. They're maybe believing things that are not even remotely accurate. We're not talking about, just slightly off. We're talking about like the FBI has put chips in my head and I've had surgeries, that where I've been kidnapped by the government, that sort of thing. There are situations where there can be a court order to have that person get help or medication or be hospitalized when they are not consenting. In those situations, they are not capable of consent either. So involuntary treatment is not a never. It's just rare. And it's not even close to the majority of what I do. I mean, I can think of one of those cases I've been involved in the last year. It's really rare. So just putting that aside, because nothing is a never, right?
Yes,
It's just
yes, thank
really
you.
rare. It's not the norm. So when people come to me, generally speaking, they've seen other mental health care providers before coming to me, just because of the nature of what I do. I am usually not the first point of contact for a person when they have never sought mental health care before. They've never seen a therapist. They've never seen a psychiatrist. Usually people are coming to me after having tried and failed multiple treatment options. That said, it still does sometimes happen that I'm talking to a person who has a lot of stigma, anti-psychiatry sentiment. And the way that usually manifests is this misinterpretation that by talking about a treatment option or by offering a treatment option at the first visit, that somehow that's being pushy, pill pushing, or forceful. And it's really weird, I think, when I compare that to my colleagues in other specialties of medicine. If you go to a dermatologist and you say, you know what, I have this terrible acne, let me tell you about how bad it is, how much it's affected my life. And they say, okay, well, let me offer you this medicine for acne. You wouldn't say, gosh, you're offering it in the first appointment, you're a pill pusher, right? You wouldn't say that because you're going there because you want some help. So the perception that a psychiatrist doing the exact same thing, this is a medical problem. You're coming to me with a medical problem. We're talking to figure out what it is, what's going on, what might be the right treatment options, and let me offer you some options, and you could start today. That's seen as somehow negative. And I think part of it is that people get a little bit confused about what a psychiatrist is versus what a therapist is. And there is a difference. So a therapist does work where they're talking you through things, but they're not offering biological interventions. And a therapist is not the person who is going to be sorting through all of your medical problems, all of your other medications, and trying to figure out, well, is there something medical going on here that isn't psychiatric medical, but is more like sleep apnea is contributing? Or is there some kind of substance that you're taking, either over the counter or prescribed, that could be contributing? Is part of what's going on that your thyroid is off, or that we should look and see whether you have, some other problem like dementia, multiple sclerosis, Parkinson's, that might be contributing or causing the symptoms that you're having. A therapist is taking what you come in with and talking it through. And they can do some diagnosis within the realm of mental health, but it's a very different role. And they're not offering medications. They're not talking about, what you can do with brain stimulation, right? A psychiatrist is a doctor, the same kind of medical doctor that you see that you send your kids to a pediatrician, or that you see when you have, an ear infection, or that you see when you're worried you might have cancer. It's the same educational pathway. It's a different end to the pathway. So all doctors graduate from medical school undifferentiated. And then where we become different is in the years after medical school, where we get training in our particular specialty. So there is a little bit of um, a different perception of what we should be doing sometimes.
So I would like to ask now for a bit of a deeper understanding, because I've heard psychiatrists as well as neuropsychiatrists. Are those the same term? Is there can they be distinguished as different? Um, how would you
So
explain that?
yeah, good question. So psychiatrists are medical doctors with MDs or DOs who went through medical school 4 years after so undergrad 4 years, medical school 4 years, and then residency 4 years. So 12 years of training. A neuropsychiatrist is a subspecialty within psychiatry where you do another 1 or 2 years training after that. So it's a more narrow, smaller group, I would say, where people get a little bit more, I would say, where it's easier to have a difficult time saying which is psychologists versus psychiatrists. And those terms are often used interchangeably. And the professional training for psychologists and psychiatrists are actually very different. So a psychologist goes to undergrad and then goes to graduate school in psychology. And generally, it's like 4, 6 years of training in how to be a therapist, training in learning about mental illness, training in how to do different kinds of assessments sometimes for thinking and memory. But there's no medical school in there. And so it's a degree that's more focused on the therapy, the talk therapy, and is not the medical side of things.
Okay, so we brought up a few things in this conversation right now.
Yeah.
Therapist, psychiatrist, neuropsychiatrist, and then psychologist. And
Psychologist.
as you're bringing this up, another movie reference comes to mind. I think it was Analyze This or Analyze That. I'm not sure if you remember that old movie where it's like I think it's Robert De Niro and Billy Crystal. And Robert De Niro, he's a mafia boss and he's a
Of course he
mafioso,
is.
of course.
Yeah.
But he goes to this doctor or whatever, and he starts crying and he says, "I have stress." Uh, I don't know if have you ever seen that movie by
I haven't
chance?
seen that movie. I've seen some
Oh,
others where of
golly.
portrayals of, I haven't seen that one. So no, I haven't
But,
seen
but
Shutter Island either. I'm sorry.
oh man, but from me bringing that up, would that sound like a psychologist or a therapist? Because he's talking and Billy Crystal's just and listening, and but he really wanted. I mean, I haven't seen this movie in 20 years, but from
Uh-huh.
what I remember is he's talking. Is that just talk therapy, or could that be considered as a psychologist?
Well, so there's a lot of overlap, which makes it, of course, just, more confusing. So in my residency training to be a psychiatrist, I did get some therapy training. In my opinion, I did not get as much therapy training as I would have if I had, not gone to medical school at all and gone and gotten a psychology graduate degree and become, a straight up I'm a therapist and this is what my training is in and what I'm specialized in. I have tended to lean towards the more medical aspects of mental health also, the more biological focus. But there are colleagues who I was in training with who are medical doctors, who are psychiatrists, who did do psychiatry residency with me, who focused more on that during their training, more on therapy techniques. And some of them even went on to do more training after they were done with all of the training that is, the 12 years that's required to become a practicing psychiatrist. They did more training beyond that in how to be like really, really good psychotherapists. So psychiatrists can do psychotherapy. These days, it's not as common as it used to be. So when Fraser came, are you familiar with Fraser?
Of course.
Yeah, okay.
Fraser Crane,
Um,
right?
Fraser Crane, he was a psychiatrist in Seattle. Here I am, a psychiatrist in Seattle. So he was a psychiatrist. I think the writers of that show often kind of didn't know what that meant. They were consistent with the term, but a lot of what they had him do what would have been, even then a little bit more typical for a psychologist than a psychiatrist. However, back then in the 90s, psychiatrists doing a lot more sort of psychotherapy, it was more common than it is now. These days, people will very often have a therapist who is a psychologist or a social worker who is separate from their psychiatrist, who a patient will often think of as their med management person, but it's the person doing the sort of diagnostic assessment, seeing if there's anything else medical contributing, and then thinking about the biological interventions more.
So, talking about Frasier, now they're having like a reboot. They're having
Yeah, I know.
so are you going to be writing letters, get it right, or
No, I mean, honestly, of all the portrayals of mental health providers on television, Frasier is one of the most benign, honestly. He was, and I guess is in the reboot, egotistical. He's portrayed as way richer than I mean, doctors usually are, much less psychiatrists. We're actually one of the much, much lower paid specialties within medicine. So he's very snooty in the show. I think that you're more likely in Seattle these days to see that among like the Amazon executives or the Microsoft executives than you are a psychiatrist, especially, giving advice on the radio. But in general, he is never portrayed as malicious or, badly meaning or overly controlling with anyone, with his patients. And I think that I'm going to give them props for that. And then, he has to have some character flaws for the comedy, and he certainly does. So,
and I think it does look good for psychiatrists, for the people who are watching it, and he's a lovable character, and sometimes he's very out there, but uh, I wanted to pause now and kind of go back because we started this conversation or this topic on how sometimes media can look at psychiatrists in a negative tone, and we've kind of built from there, and we've unraveled that your reasons to becoming a psychiatrist were of good intent, and had good motivations, and you really established that. And before we continue, I wanted to thank you for establishing that you're a person who has that desire to bring hope and to uplift people instead of bringing them down. And I think that that's very important that we establish that in the very start of this interview.
it's hard
Now,
to imagine what the motivation would be for bringing people down. I think I think very occasionally I've had a patient say to me something about money, like you just want to give me this treatment because of money. And and weirdly, it's usually about electroconvulsive therapy. And honestly, that is the worst paying thing that you can do. And I mean, it's so there's just there's no strong financial motivation to go into psychiatry. When you're in medical school, everything else is going to lead to a better, lifestyle. And there's, within psychiatry, very little in the way of financial motivation to offer one treatment, or another, generally speaking. So it kind of baffles me, but also, right. I mean, that's the perception that people have. And I think it's coming from a place of sort of fear and media and yeah, all that stuff.
Well, I'm ready to baffle you a little more, if I
Okay.
may, if I may. So for
Yeah.
the next part of our interview, because for those who have listened to this podcast, I have been very open about my journey, and I've been very like in real time sharing my journey of healing after leaving the cult and developing friendships and a more deeper understanding of healing, both spiritual as well as mental healing.
Mhm.
So I want to baffle you with some of the concepts that were held within this group,
Mhm.
and I'm not trying uh, to put down anyone's religious beliefs. In this podcast, I truly believe in respect and giving dignity. However, these are things which I experienced, and so I want to bring them up, and you know, maybe you can shine a light on them. And in your perspective, so kind of comparing the concepts that I had within the cult, bring that up and hear what you have to say about it, if it's a healthy or a negative approach. So,
Mhm.
are you ready?
Yeah. Yes.
Okay, so one thing that was really strong in the cult or this religious group was depression. The way depression was, uh, the way it was defined was, it is a phase. It is a person being in a state of crisis. So there are different ways to remedy this. The first remedy would be kind of like a talk therapy. That person will talk with the superior and uh, share with them his or her problems, and then the superior will give advice.
Mhm.
That was one remedy. When that doesn't work, it it became, we need to isolate the member, keep them separated, make them be alone so they can pray their way to have clarity of mind. And that with this separation and silence and prayer, they're going to reach, uh, they're they're supposed to be able to cleanse themselves from that depression, or as I mentioned earlier, the way they coin it is uh, crisis.
Mhm.
And when that didn't work, and when I say that didn't work, I'm referring to some cases of people having episodes, breaking down and acting very abnormally. And because there was this fear of going to doctors, what would happen was, well, God can't help you, buddy. So they would just send them back to their parents, and that would be then wipe your hands and you go on with the community would go on with their lives. Now,
Mhm.
bringing that up, at that time, I was very skeptical, but that was what we believed.
Yeah.
You, as a psychiatrist and as a mental health expert, were there any positive things in there, or do you think that many of these things can actually have the opposite effect?
Well, sure. So talking through things, there are times when people have periods where their mood is very low, and it's because something bad has happened. It's because there is some crisis. Grief is a very good example. The As one of my patients said to me last week, the fatality rate of humans is 100%. So grief is very common, and it's really difficult to deal with. It's very, very painful. And it isn't necessarily, a mental health problem unless it goes really sideways. So it is a normal, terrible, awful, painful, but also normal human experience. So talking that through, that is a very reasonable first step. And when a person has a slide into depression, if it's mild, if it's moderate, trying talk therapy first, there's nothing wrong with that, right? And that is a very tried and true tested kind of treatment. Now, whether the talk therapy they were getting in your religious group was very well trained or targeted, I mean, not all talking is the same, right? And therapy is different from conversation, and then there's different types of therapy. And so I think it's hard to know what was happening there. Then having prayer as a next step, there are many situations and many, many other groups in history that have thought that silent pursuit of wisdom or prayer can be very helpful. So meditation is something that's still quite popular now. I believe it was the first penitentiary in the United States in Philadelphia, which you can tour. That the idea behind the penitentiary is that people who had done wrong, who were, criminals, prisoners, would sit in silence and isolation and read the Bible endlessly, and that was supposed to be healing. So that is not a new idea. And then there were, of course, monks with vows of silence, and those were not even just in one culture; those were in multiple cultures. So you can't say there's nothing to that. However, in the modern perception of depression in our culture right now, isolation seems to not be the right call. And we saw this a lot in COVID, where it was forced isolation, right? And there were very few people who felt a little bit better. So people with severe social anxiety early on were like, okay, well, I don't have to do that. But that didn't last very long, actually. By the time this thing was dragging a year, 2 years, it was very hard to see anything positive in terms of the isolation that people had to go through for the pandemic. And people with depression getting isolated, that's a lot of what people feel like doing when they're depressed anyway. So if you're a person with depression and you feel like you don't want to go out, you want to stay in bed, you don't really want to shower, you don't want to change your clothes, you don't want to talk to anybody. If you do all of that, if you say, okay, yes, I'm not going to get up, I'm not going to go out, that makes you more depressed. So that's not to say that it's always easy to resist those impulses. And it's not, and that's the nature of the illness. But telling somebody to lean in, and sure, don't get up from bed, stay home, don't talk to other people. Generally, that's considered to be telling them things that will make their depression worse. And then the last step there was sending them back to their families.
Yes.
I don't know that I have much to say about that, because I'm not sure then what their families would do. So.
Well, they were pissed.
Oh, really? Okay.
I so understandably, but still, the thinking is for some people, I can't get mental health treatment, or I can't go to an expert because I can't trust them. And so, that's, I think, one of the reasons why I really wanted to build upon very early in this interview is that you're human beings. And I think, some of the ways that we were taught was to look at you all, doctors, psychiatrists, or psychologists, as malicious people just trying to brainwash us. But but it's really bringing to light a more fuller picture, hearing your side of the story.
I think it's very ironic you said the word brainwash, because some of the before we started recording, some of the things that you told me that your group did, those are known, tried and true brainwashing techniques. Having somebody be very, very tired, very hungry, isolated, only have contact with certain people, that's a great way to exert control over someone.
Now, another thing that I would like to, get your view on is uh, what is depression? Because the side that I brought from the cult, where it's simply a state of being in crisis. It's a phase, but it didn't go anything deeper than that.
Mhm.
What is the true definition of depression, and are
Yeah.
there degrees in it?
So depression, the way that we use vocabulary in medicine, we try to define it as precisely as we can so that we know we're all talking about the same thing, right? Does that mean it's the one and only way of looking at it? No. But when a psychiatrist, a psychologist is looking at, does this person have depression, or what we would label with that word depression, we are looking at how long has it lasted. A depressive episode needs to have been at least 2 weeks. We're looking at what's happened during those 2 weeks. Are you spending most of the day, every day, feeling down, sad, hopeless? Are you feeling more guilty than is warranted by, what's going on or circumstances? This just excessive, weighty guilt. Are you feeling like you can't get out of bed, like you're so tired? Are you feeling like you can't sleep, or like you're sleeping way too much? Is your appetite different? Is your energy, your motivation really different? Are you able to enjoy anything, or is the joy just sucked out of life? If you have a number of those symptoms most of the day, every day for 2 weeks, then we would say, okay, that's depression. That's what we would put that term on and say that's depression. People in the world use it very differently. They're like, oh, I was depressed that day. I felt depressed after that happened, after I read about that bad thing. And there's nothing wrong with saying that term. It's just we mean it's something different when we're talking about, okay, is this something where we would consider a biological intervention, where we would consider it to be a problem instead of a normal emotion, right?
No,
Um,
I really I like that because in the world, the world, but we see depression a little
yeah.
bit different. But it's good to also understand, that uh, precise understanding. And I've spent some time in Seattle. It's a very cloudy city. I would have my coffee shop. There was a coffee shop that I would go to, and someone shared to me one time that there is a depression problem in Seattle. And I asked why. It's a nice city, it's hip, it's cool. And this person was saying that it's always so cloudy, there's not enough sunshine. Um, is that depression, or does that contribute to depression, or is that just like, everyday talk? Oh, I was, depressed, I was down.
So I think I would need to probably look at some numbers in order to figure this out, but it's actually, really hard to say which places have more depression and don't, because you're not surveying everybody and asking how they're feeling. You're, looking at who's accessing mental health care, right? And who's getting diagnosed and who's getting treated. And those numbers are very skewed depending upon how wealthy the area is, how many people have insurance, how many mental health care providers there actually are. So when I look at statistics of, this city has way more of this condition or this condition, you have to take that into account. Well, what about all the people who maybe have this who aren't seeking care, right? Or who aren't being caught. So do I think Seattle has a worse depression problem than, say, other places I've lived, like Boston or Palo Alto or Oakland? Not really. I don't. Could somebody argue with me about that and present some data saying I'm wrong? Yes, they certainly could, but that isn't my impression. I do think that we have some people who are vulnerable to weather changes and changes in light exposure who do get better and worse depending upon the time of the year. That has as much to do with the days being shorter as it does to do with the cloudiness itself. So we see that when the days get shorter, some people who are vulnerable to those shifts will be helped a lot by using a full spectrum light for like 30 minutes in the morning, sort of at oblique angle to their eyes, kind of like if you're looking at a computer screen, sort of next to the computer screen and sort of shining diagonally into your eyes for 30 minutes, that can help a lot.
Well, thank.
Sometimes, people who have depression that comes and goes. So depression tends to be what we call a relapsing remitting illness. It tends to be episodic, meaning a person who has depression, sometimes there are people who are just depressed all the time for years and it never goes away. And I do see a lot of those people because of the nature of the treatments I offer. More commonly, people have episodes of depression where they're really, really down for a few weeks or a few months, and then they aren't for a while and they're actually feeling okay. And then they'll have another episode where they're very, very down, depressed for a few weeks or a few months. And it's not, a regular rhythm usually. I can think of one patient I had who had a really bad episode, and then the next one wasn't for 4 years, right? And some people, it's a little bit more frequent. So they'll have like 3 bad episodes in a year. So there's a lot of variability in how depression presents. I think that there are many people out there who only ever have one episode and then never again, and that's great. And those don't tend to be the people who I end up seeing, though. And very often they aren't people who psychiatrists end up seeing, because they might not seek help at all that first episode, or they might go see their primary care doctor and, get something like Prozac or Celexa, and it works. That does happen. So.
Yeah, well, I don't like using real human beings as examples. So we've been talking a lot about movies and media. Um,
Right.
I wanted to use as an example Eeyore. I don't know if you know who
Sure.
Eeyore is
Yes.
from Winnie the Pooh. I don't know if you ever watched that in your childhood, but
Uh-huh.
would that be an example of uh, perhaps mental health, depression, or is that just his personality?
Oh, I don't know. I mean, he's a stuffed animal, so I just kind of want to give him
Well,
a hug and tell him
I
maybe he's
mean,
gonna be
yeah,
okay.
I know he's a stuffed
But
animal, but I mean
but Eeyore
the character.
he is an example of what I would call dysthymia. So he's always kind of down. But is he getting to the point where he's so depressed that he's not getting out of bed, where his appetite is affected, where he's saying, no, I'm not going to do things? It's hard to say. He might meet criteria for major depressive disorder, but in his case, it's certainly not episodic. It's all the time. Is he saying he wants to die? I mean, no, maybe he feels that, but it's a children's show. So um, I think of Eeyore as being, in the show meant to be a personality manifestation of how a human can be in different states on different days. These animals are representing those different states and different days, and they're these archetypes and exaggerations. And he's the archetype and exaggeration of a bad day and a bad mood, right?
Wow, thank you for really illuminating Eeyore in that way. Thank you. I think that settles the issue regarding depression. Now there's another important thing that I would like to talk about from the cult that I was in, and that is sleep. Now
Mhm.
the ways well there were two different scenarios that we went through. One scenario was you get 5 hours of sleep, but in the middle of that 5 hours, they wake you up, and let's say they wake you up at 11 p.m. So they wake you up at 11 p.m. You have to be awake from 11 p.m. until midnight, and then you go back to sleep, and then you wake up again at 3 o'clock. And that was seen, and we were struggling. I remember, you know, hitting ourselves to stay awake, because if we don't stay awake, there would be no, we'd be punished by having our food taken away, or other punishments, which I don't want to, bring up. But it was seen as something noble. It's like, wow, we're fighting to stay awake, and we're interrupting our sleep to stay awake for an hour and then go back to sleep and then wake up again at 3 o'clock. And at that time, it was seen as something noble and something good. Spiritually, maybe, but I would like to ask you, what does that do to the body, and more, what does it do to the brain?
Well, it's torture. I mean, what you're describing is torture. Um, I think that, I mean, I hope, I guess, that being in a cult um, is not the most common experience. I hope. Being abused is a very common experience. Lots and lots of people get abused in households by people who may or may not know that they're being abusive, and it may or may not be intentional. But lots of the ways of keeping a person controlled and down and dependent and is leading them to believe that what they're doing has, some that has some purpose, right? Like, you have to do this or else something bad will happen, or else you aren't a good person. And keeping a person sleep deprived is a great way to put the brain into a place where you're just not able to process or resist or think clearly, right? As I'm sure you know, having done it. The brain has a really complicated sleep pattern for a reason. And we're still working on what those reasons are. And it's an absolutely fascinating area of scientific inquiry and a fascinating area of medicine. But our brains are really, really busy when we're sleeping. And they're busy doing different things in different parts of our sleep cycle. We sleep for 7 to 9 hours, generally speaking. And during that period of time, you have generally 4 sleep cycles where you're starting in a shallow stage of sleep and you're going down into slow wave or deep sleep, and then coming back and then having the shallow sleep and having a dream. So with the REM, rapid eye movement period, then doing it again and doing it again. And each cycle is a little bit different. So the first cycle, you spend more time in slow wave sleep, and then a little bit less, and then a little bit less, and a little bit less. So if you're looking at like a trail on a graph, it looks like it sort of gets shallower. We have lots and lots and lots of data from laboratory studies, sleep studies, that people who do not sleep long enough, or people who have their sleep interrupted, are very impaired in critical thinking, very impaired in their ability to remember things, very impaired in their processing speed. And we also know that people who are, sleeping normally, sleeping well, we know what sleep is supposed to do. So sleep is supposed to help us throw away memories that are not needed. And we do forget most everything that happens to us, actually. Like, it's much easier to remember what we had for breakfast this morning than it is last Thursday or last Friday morning or the morning before, because it's just not worth remembering. So we remember only very important things, and sleep helps determine what those things are. And so it helps solidify things that should stay in your memory and let things slip away that shouldn't. It consolidates information. So what that means, a good example of this is a study where groups of people were asked to memorize a list of words, and then they were retested on that list of words later. And they either slept between learning the words and getting retested, or they didn't. So either they learned it in the morning and they were retested in the evening, normal day in between, or they learned it in the evening and were retested in the morning, night of sleep in between. And what happened with this list of words, which in one example was like pane, frame, blinds, view, sunshine. So words that were relating to window, but the word window was not on the list. So people who were retested at the beginning, from the beginning of the day to the end of the day, no sleep, they remembered window wasn't on the list. When a person learned the list before sleeping and then were retested in the morning after sleeping, they remembered window being on the list, because what's happening during sleep is that your brain is putting things together in order to make the world make more sense, in order to provide insight. And there's some very good examples of, brilliant minds coming up with insightful ideas while they're asleep. And the periodic table was one of them. It came it came in a dream. So I mean, certainly he was thinking about it beforehand, right? But it was an insight that happened after a night of sleep. And the way he perceived it is that, came in a dream or came during sleep. But that makes a lot of sense given what we know about sleep and what it does with the brain. There's a lot of housekeeping that happens in the body during sleep also. So people who don't sleep well are at a much higher risk of having heart attacks and having strokes. People who don't sleep well don't develop immunity as well as they should. So there's some really interesting studies of giving people vaccines and then seeing a few weeks later, well, how well is the vaccine working? What are the titer levels, they're called, in the blood? If they slept really well the night after the vaccine versus if they didn't sleep very well. And that first night of sleep after getting a vaccine actually makes a lot of difference to how your body's doing with that immunity a few weeks later. So lots and lots of things that are important about sleep. And sleep deprivation is a really classic way of exerting control and having people obey in a group. Yeah.
And there was a second scenario that we encountered, and this is later on, but it's like this. It's 10 p.m. sleep,
Mhm. Mhm.
rising is 12:45, and as you're falling asleep during the day, they would uh, designate people to get a stick and keep you awake. So you're constantly being forced to stay awake. But I remember in my experience, because I was one of those in crisis, so I was in isolation, uh, getting my sleep. But I would think to myself, wow, I'm 25 years old, but I was wondering at that time, what has happened? Why do I still feel like I'm 15 years old? Because well, when I joined, I was 17, and then boom, straight to that sleep deprivation. And I'm wondering if the lack of sleep does that also contribute to a lacking of maturing for people? Does that
Mhm.
keep the brain stunted?
I think there's probably a lot of factors there. Does lack of sleep impair your ability to learn? Yeah, absolutely. Does it impair your ability to control your emotions? Yeah, absolutely. Does it impair your ability to think reasonably, to think critically? Yes, it does. Is that the reason why in that setting you felt like you were still a teenager? I would hypothesize, and this is me just shooting it out there because, you know better than I do what you went through. A setting like that is trying to keep you feeling like you are not an adult in control and capable of making your own decisions and capable of exerting independence, because that is antithetical to what they're wanting from you. And so feeling like a teenager, feeling like a child actually serves that purpose really well.
Well, what I'm trying to get to is that I did start stealing sleep. And as
Mhm.
I would steal sleep, I would be able to, look at myself and kind of self-reflect
Yeah.
and see what the hell is going on.
Yeah.
And but I don't want this podcast to be all dark and gloomy. Um, but uh, what advice can you give for those who may have left the cult or who may have left a dark place in their life and they are in need of help, but they may be afraid? What words of wisdom, or maybe like what would be the first steps that you would encourage them to do to start that journey?
Yeah. Well, I think one can, there's two ways things can go. You can fall into the same trap again and be over trusting and get sucked back into something similar. People who are abused very often end up back in the same situation where they're being abused by somebody else and then maybe again. And it's because the brain is sort of, um, it, it has grown in ways during that time where the kinds of things that are associated with the abuse or with the person who previously abused them also seem like, good or attractive traits for the next person that they're choosing to be with. And I'm thinking here of romantic relationships in particular. And I'm pretty sure that can happen with cults or groups or other sort of negative group settings too, right? So you can go that way and repeat it, or you can overcompensate, go the other way, and never trust anyone again, even people who you should. And I think that's a challenge, trying to find that sort of middle path between those extremes, and it is not easy. I think one thing to do is to realize that help is not from any one particular place. There is no one person who ever has the answers. And if you see somebody who is telling you, I've got all the answers, I'm the one who's going to help you, nobody else is, you shouldn't see anybody besides me, only listen to me, big warning sign, ding, 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 red flags. All right. I don't know a doctor who would ever say that. I mean, the idea of a person coming to see me and then listening to what I have to say and then being like, oh, I'm not sure, and then getting a second opinion, that's actually fine. That's how it should be, right? And if they get a second opinion and another psychiatrist is saying something very different than what I'm saying, then it's good for me to know that. And, well, do they know something that I don't, or do I know something they don't? So it's meant to be a collaborative thing. Also, finding people to help you who are themselves monitored, right? So a doctor in a group setting, or who has connections in the medical community, might make you feel safer. That's not to say that people who are, on their own alone in private practice, that there's anything wrong with that. No, it's definitely great. If you're coming from a place of feeling not trusting, though, knowing that they're part of a university, for example, and knowing that they're, in a large group of other people who do the same thing, so that if they have any questions or concerns, or, there's an issue with your care, there's other eyes on it, right? That might also, sort of help with trust and help get to the point where you're thinking that people who are trying to help you are actually trying to help you.
Thank you so much, Dr. Allen, for really bringing that to the front of it being a collaborative effort, not just from one doctor, but from multiple people. And it's okay to have a second opinion. No need to
Yes.
no need
Yes.
to feel afraid or I'm gonna hurt the doctor's feelings. Or does it happen? Do you do the doctor's feelings get hurt when someone says, you know what, I gotta get a second opinion? Is that offensive for
I
some?
mean, sometimes I suggest it. Usually I suggest it when a person thinks that what I am proposing is not what they want to hear. So that's most often when yeah, so if a person, for example, is on a medication that can cause dependency and cognitive problems, and they really, really don't want to not be on that medicine, asking, would you be willing to see somebody else? If you think that my take on this is really off base, would you be willing to see somebody else who you could ask these questions and see whether I'm really off on this. But if a person's like, I'm not sure that I want to, think about this medicine or that medicine, I'm not sure that you're, coming up with everything out there, I think it would be wrong. I mean, and I think it would be wrong to get offended, for somebody seeking, somebody else weighing in on their case, on their situation. And generally speaking, physicians are used to working collaboratively. I mean, I don't take care of every aspect of a person's health. I should be able to talk with the person's primary care provider if I think maybe there's something going on, here that's a little bit more in the physical realm, like a thyroid issue or, blood sugar diabetes issue or sleep issue. I should be able to refer them to neurology if I think they need a sleep study, or if I think they need an evaluation for some kind of movement disorder. So we should be talking to each other. We should be collaborating. Sometimes for patients that can feel chaotic. There's some comfort in being like, well, I'm going to one person and they do absolutely everything. But then you don't get the expertise that you need, because medicine is so big now, so big that nobody can know it all. Nobody can. And I actually think primary care doctors have the hardest job in medicine, 100% the hardest job in medicine, because they have to know something about everything, right? And they have to recognize everything to the degree that they at least, can address it with a first or second treatment, or, know when to refer. It's really hard to be a primary care doctor. So seeing multiple specialists and getting multiple opinions, I think the way to look at it is it's education. You're going and seeing a doctor and you're hearing what they have to say, what their thoughts are. You're asking questions, and you don't have to do anything. Just because you saw a doctor and they say you should be on this medicine doesn't mean you have to take it, right? But at least it's out there, the reasoning behind it, why somebody would think about that.
No, thank you so much for clarifying that, because, coming from a background where we were taught that you have to, you can't ask questions, you don't want to offend them. When I say them, I mean higher ups. So someone who might have left from a setting or an environment such as the one that I was in might still carry that with them and be afraid to voice their opinion or share their thoughts. And I think it brings peace hearing you say, it's okay, go ahead. It's okay. I'm not going to be offended. I'm open to that. And I think that I've really learned a lot from this discussion, Dr. Allen, and I wanted to thank you once again. And to kind of close, do you have like a website, or are you taking patients, or how does that work?
My practice is taking patients, yes. So we are Seattle Neuropsychiatric Treatment Center, and our website is www.seattlentc.com. And we have 5 clinics in the Seattle metro area, so up north to Bellingham, down to Tacoma, and also over on Kitsap and Seattle and Bellevue as well. And our specialty is treatment-resistant conditions. So people who have tried the more first-line treatments like oral medications or talk therapy and are still suffering. So that is where we have something to offer that is different from other places, for sure.
And is this reserved only for Seattle, Washington residents?
So there are issues of licensing in medicine where seeing a person who lives in a state where you don't have a license to practice is not allowed. So I think that generally speaking, given that our treatments, a lot of them do need to be done in person, that it is hard to treat people out of state. And so you can treat people out of state if you have a license to practice there, but you're limited to then talk therapy or prescribing a medication that you send to their pharmacy. For coming to do something like ketamine treatments or electroconvulsive therapy treatments or transcranial magnetic stimulation treatments, it's in person. So it would be hard to offer that unless a patient knew that they were going to be able to come in person for that. We are about to start offering a version of transcranial magnetic stimulation that is done over the course of 2 weeks, where you get a brain scan the first week, and then your treatment is based upon what's seen in the brain scan. It's a customized location for targeting the treatment, and then the treatment itself is 10 times a day for 5 days. So for that particular treatment, which is called SAINT, that would be something where a person could come from very far away and do it, and it wouldn't be unreasonable. For a lot of other treatments where you're having to get, 2 treatments a week or 5 treatments a week for weeks in a row, it's pretty hard to sort of come in from far away and do that.